presentation by Roberto Tamburro from University of Teramo, Italy, presenting on the title Evaluation of Prophylactic Antibiotic Treatment in Dogs Underwent Tibial Plateau Leveling Osteotomy. Doctor, now the stage is yours.
Thank you. Good morning, everybody, and greetings from Italy. First of all, I would like to thank the board of the Global Summit on Animal Science and Veterinary Medicine for inviting me in this important meeting. It's a great pleasure to be part of it. My presentation is titled Evaluation of Prophylactic Antibiotic Treatment in Dogs Underwent Tibial Plateau Leveling Osteotomy. The cranial cruciate ligament disease is the most common orthopedic disorder involving mainly dogs, but cats as well. And cruciate disease leads to joint instability with evidence of pain and lameness and consequent osteoarthritis development. Clinical cruciate disease normally involves adult dogs presented with history of lameness responsive to non-steroidal anti-inflammatory drugs. At clinical examination, there is evidence of positive test, evidence of medial buttress, and as evidence of positive tibial compression and drawer tests. Clinically, you can see in this short video on the left side, the dog with evidence of grade 3 lameness on the right hind limb. But from the other point of view, you can see dog with very, very slight lameness. In this case, there is a dog with evidence of grade 1, grade 2 left hind limb lameness. The cranial cruciate disease basically recognizes a clinical diagnosis, and palpation, it is very, very important. We have actually two main tests that could be performed. The first one is the drawer test, and the second is the tibial compression test. The drawer test is a static one in which the operator is going to move cranially the tibia, and in case of cruciate disease, we can appreciate a cranial dislocation of the tibia in relation to the femur. The tibial compression test is a dynamic test in which we are going to simulate what normally happens during the dog weight bearing. And flexing the hock joint, we can appreciate a cranial displacement of the tibia as well. In this short video, you can see on the left a dog with evidence of a positive cranial drawer test that is achieved by pushing caudally the tibia. And in the tibia compression test, we can see that by flexing the hock, we can easily appreciate a cranial displacement of the tibia that is related to the cruciate disease. Again, in dogs affected by cruciate disease, it's very common to observe the medial buttress that is described as a fibrotic thickening of the medial aspect of the tibial bone that is actually related to the cruciate disease, and is very useful from diagnostic point of view, especially in dogs with unilateral pathology. Of course, this kind of pathology may be recognized using X-ray that are normally performed in mediolateral and caudocranial view in dogs under general anesthesia. And radiographic findings associated with cruciate disease are normally divided as a specific sign and aspecific signs. The main specific sign is a changed anatomic relationship between femur and tibia, because we are going to perform a stressed X-ray in which the tibia may be pushed forward. Aspecific signs include the fat pad signs, osteoarthritis development, and caudal dislocation of the popliteal fascia. In these two X-ray, you can see on the left side dogs in which there is a clear evidence of a fat pad sign described as an increased radiolucency into the stifle joint. You can see osteoarthritis development that normally starts from the distal aspect of the patella. You can see again a slight displacement of the tibia in relationship to the femur and a caudal dislocation of the popliteal fascia. In these other X-rays, you can see again a fat pad sign. You can see the osteoarthritis development in the caudal in the distal aspect of the patella, and again the caudal dislocation of the popliteal fascia and the severe cranial displacement of the tibia in comparison to the femur. So the cruciate disease normally recognize a surgical treatment, and in veterinary literature there are different surgical procedures that aim to treat the cruciate disease. One of the most important for sure is the tibial plateau leveling osteotomy that was firstly described by Barclay's Locum in 1993, and so far is probably the gold standard surgical technique to manage the cruciate disease. The TPLO aims to provide a dynamic stifle stabilization that is allowed by achieving a 90-degree angle between the tibial plateau and the patellar tendon. The consequent radial osteotomy is fixed by using a pre-angled plate. The outcome by TPLO are very, very nice, and normally dogs with cruciate disease may have a complete restore to function. For example, the last one on the right is a dog at 100 days postoperatively of a bilateral TPLO surgery, and actually this is what normally happens in dogs affected by cruciate disease treated with TPLO surgery. And so we have a good restore to function with satisfaction by the owner. Again, of course, this kind of pathology is associated to several complications. In 2012, has been published in a paper by Berg and Peirone, in which complication of tibial plateau leveling osteotomy in dogs have been reported, and authors reported complications that may range from 10 to 34% of cases. TPLO complication may involve soft tissues, may involve bone tissues, and implants as well. And paying attention to the soft tissues complication, the surgical site infection rates may range from 0.8% to 14%. So the surgical site infection is basically spread by the patient. Of course, it may be spread by the staff and surgical equipment as well, and may be also related to the surgical invasivity and the surgical duration time. So actually, what can we do in terms of prevention of surgical site infection? Normally is to use antibiotics. Antibiotic use in orthopedics is very common because the orthopedic surgery is associated to high risk of infection. And so antibiotics use aim to avoid any potential surgical infection, recognized as a postoperative complication that may lead to morbidity and may lead to surgical failures. So ideally, an antibiotic, according to the Centers for Disease Control and Prevention's guideline, should have a proper concentration into the surgical site, overall the entire potential contamination period. We have to remember that an antibiotic cannot replace a proper surgical aseptic procedure, cannot replace an traumatic tissues handling and a proper hemostasis. From the other point of view, an inappropriate antibiotic may have no effects in terms of infection prevention, but may have systemic toxicity and increase the potential antibiotic resistance. We know that the antibiotic resistance is the bacteria ability to survive at higher antibiotic concentration, and it occurs when bacteria change in response to the use of this medicine. According to the World Health Organization, we know that the antibiotic resistance is one of the most relevant public health problems of our period, involving humans and involving animals as well. In 2019, in Europe, 33,000 of people died for reason in relationship with antibiotic resistance, and 11,000 just in Italy. What can we do? What can we do? Of course, today is an antibiotic treatment that is actually divided as perioperative and postoperative. The perioperative treatment is performed around the surgical procedure 30 to 60 minutes before the skin incision, and it's repeated every 90 minutes and stopped within 12 to 24 hours after surgery. Normally, the cefazolin at the dose of 22 to 30 milligram per kg IV is the main drug that is administered. We have also the postoperative medication that is a very common practice in veterinary medicine. And the main antibiotic used are cefazolin at a dose of 22 to 30 milligram per kg for 7 to 10 days. Alternatively, we can use amoxiclav at a dose of 12.5 to 20 milligram per kg for 10 days. But the TPLO surgery is considered a clean orthopedic procedure. So it means that it's an elective procedure in which we don't have previous contamination and in which normally we have standard surgical duration time. According to this, our hypothesis was basically that the perioperative antibiotic use may be sufficient to maintain the overall surgical site infection rate in dogs that underwent TPLO surgery. So the aim of the study was exactly to compare the perioperative versus perioperative and postoperative antibiotic use in dogs that underwent TPLO surgery. The present study was accepted by the Ethical Board Committee of the University of Teramo. Inclusion criteria were dogs underwent TPLO surgery at the veterinary teaching hospital of the University of Teramo. Dogs were randomly divided in two antibiotic protocols, Group A and Group B. Each dog received an intraoperative culture swab, and clinical recheck were performed 12 days, 30 days, and 60 to 80 days after surgery. X-ray follow-up were recorded at 60 to 80 days after surgery. Body weight and age of each patient were recorded, and the surgical site infection rate were analyzed. The group A, the perioperative group, received cefazolin at a dose of 22 milligram per kg IV, preoperatively 30 to 60 minutes before the skin incision, and then repeated every 90 to 120 minutes up to the end of the procedure, and then stopped. The control group basically received the perioperative treatment that was continued and extended in the postoperative period, always with cefazolin at a dose of 22 milligram per kg per os for 10 days after surgery. All the procedures were performed in two different rooms. In the induction room, dogs receive anesthesia, general anesthesia, local regional anesthesia, and the clipping. Then the dogs were moved into the orthopedic theater, where there was a standard aseptic preparation with chlorhexidine at 4%. And all the procedures were performed by the same veterinary surgeon. The postoperative management were all performed by the owner in the following way. Basically, the dog received 4 weeks of strict cage rest, a Robert Jones bandage for 48 hours, a Basser collar on up to the suture removal, 4 weeks of non-steroidal anti-inflammatory drugs as medication, ice pack therapy 3 times a day for 10 days, and wound management with chlorhexidine 0.5% 3 times a day for 10 days. The group B, just the control group, received cefazolin 22 milligram per kg for the following 10 days. We considered infected dogs with evidence of culture swab positivity, with evidence of wound dehiscency, with evidence of fistulization and radiographic signs of osteomyelitis. Not infected dog with evidence of bone healing within 8 to 10 weeks postoperatively. The surgical site infection rates were statistically compared between the group A and the control group using a commercial available software, and the p-value was set at as lower of 0.05 as statistically significant. So these are our results, and in the group A, the perioperative group 1, we include 43 dogs with 51 TPLOs. The mean body weight was 19 kilos, ranging from 3 to 55 kilos. The mean age was 5 years old, ranging from 2 to 11 years. The surgical site infection rate was 3.9%, 2 on 51. It is nice to recognize that all the intraoperative culture swab were negative and no implants were removed. In the control group included 59 dogs with 61 TPLOs. The mean body weight was 23 kilos, ranging from 4 to 65 kilos, and the mean age was 6 years old, ranging from 1 to 10. The surgical site infection rate was 3.2%, 2 cases on 61, and no implants were removed in this group as well. The statistical comparison between the group A and the group B in terms of surgical site infection rate gave us a p-value higher than 0.05, and so no statistical differences has been observed in terms of surgical site infection. This is a dog from the group A. It's a dog mixed breed, female, 18 kilos. This dog had unilateral TPLO surgery that was fixed using a fixing locking plate. And basically, 60 days after surgery, you can see a complete healing of the osteotomy without any problems related with the surgical site infection. But the other dog is a dog pit bull female, 5 years old. This dog has a TPLO surgery in which there was a negative intraculture swab. But unfortunately, 10 days after surgery, there was evidence of wound dehiscences. And we performed again a new intraculture swabs that was positive to Serratia marcescens. This bacteria was resistant to the main antibiotic that can be used and was sensible to enrofloxacin that was given at the dose of 5 milligrams per kg for 15 days. And as you can see from the X-ray, fortunately, we were able to obtain a bone healing at 18 days postoperatively. The second case in which we had infection is again a dog mixed breed male, 55 kilos, in which the intraoperative culture swab was negative during the surgery, but 15 days after surgery, there was a fistulization in the distal part of the wound. And again, we performed another culture swab with evidence identification of Staphylococcus hominis. Again, this bacteria was resistant to different antibiotics. And so we decided to treat this infection using the enrofloxacin at the dose of 5 milligrams per kg for 10 days. And fortunately, again, we achieved the bone healing within 80 days postoperatively. So the use of antibiotic treatment during TPLO is very controversial. In 2021, was published on veterinary surgery a review paper of the efficacy of postoperative antibiotic use after TPLO. The authors reviewed a paper in which there was a clear antibiotic treatment and in which the surgical site infection rate was clearly reported. On different papers reviewed, just 13 met the inclusion criteria, and basically the TPLO surgical site infection rate was between 3 and 26%. But in the end, the author concluded that the clinical impact of postoperative antibiotic administration on infection rates after TPLO is still uncertain. So what can we do? Of course, we should improve our knowledge. We have to promote prospective study, because the aim is to use useful antibiotic treatment that are able to control the surgical site infection without promoting the multi-drug resistance. In the present study, the surgical site infection rate associated to the perioperative antibiotic use was 3.9%, and the statistical comparison between the perioperative group and the control group was higher than 0.05. So it means that actually the perioperative antibiotic use may be sufficient to control the infection rate during TPLO surgery. The intraoperative culture swab was always negative in the group A, but we recognize that in 2 cases we had infection respectively in 10 days and 15 days after surgery. So actually the intraoperative culture swab is very useful, but cannot exclude any potential infection. And so the clinical recheck and follow-up are very, very important in order to recognize any potential infection. From the other point of view, the intraoperative culture swab, it is very useful because in case of culture positivity, may provide an evidence-based treatment. And so in this way, we can probably avoid any potential antibiotic resistance development. It is again very important to recognize that the surgical site infection prevention is related to a proper surgical technique, a proper postoperative management, and the proper scrubs and a proper use of a dedicated theaters for this kind of surgical procedure. In the end, it is very important to have a very good communication with the owner, because all the post-operative management is basically performed by the owner. So it is very important that they have better understand what they have to do. In conclusion, in this study, actually, we recognize that the perioperative antibiotic treatment is sufficient to maintain the overall rate of surgical site infection at a similar level to those obtained in dogs underwent postoperative antibiotic treatment in course of TPLO surgery. So thank you for your attention and enjoy.
Thank you for that valuable presentation, Doctor. Now the stage is open for questions. I assume that you have no questions from the speakers. Once again, I thank you for being a part of this webinar and hope you associate with our future events, Doctor.
Thank you. Bye-bye.